Hi, uh, good day for everybody. As I promised that I will start the English videos also regarding the neurosurgery. As I am creating the library for the vlog library for the neurosurgery in Urdu or Hindi language, and for the actually teaching purpose, education purpose, or information purpose for all kind of the patients and the doctors and the health workers. And even though the people are presenting themselves in the conferences, if they have some background knowledge, they can express themselves, they can talk very much categorically and logically. In that manner, I realized that even though when you are presenting in Urdu or Hindi, actually it is very tough to get the attention from the people. I don't know, but now I'm trying to represent myself in English language. What I have, definitely English is not my native language, but definitely I learned and passed a lot of exams in English. I presented myself in English language. Definitely there is some defects or some lackings in me when I perform that lecture. But I think you will bear me, and definitely I will try to convey my message to you as soon as possible. So I am Dr. Mohammad Kazafi. I am a neurosurgeon. I am a working, practicing neurosurgeon. My subspecialty is the neurospinal surgery, but I am doing the general neurosurgery also, and vascular neurosurgery also I am doing. But the spinal surgery is my passion, and I want to do more. But right now, I want to present in front of you case. You can say the two cases one by one, and in this case, these are all real cases which I have dealt in my life, in my experience. I have 18-year experience as a consultant neurosurgeon in different parts of the world. So I just want to represent myself in that regard. That this topic I will present you in two cases, and both cases are real-time cases, and how we treated, how we diagnosed, how we managed these cases, what was the outcome, and then definitely some knowledge I will put in. So if you can listen, you can understand for your betterment. Maybe this introduction little you consider it's long, but I am satisfied. That's why I can make you satisfied. Now I am starting. My topic is a Chiari 1 malformation. Chiari 1 malformation, and this is the 44-year-old female presented to us in the ER with the complaint of long-standing neck pain and occipital headache. Her headache is exacerbated with neck flexion, coughing, and sneezing. She also has intermittent numbness in her fingers, and she believes her grip is strengthened as weakened over the past few years. Means she believes her grip strength when she is catching something, her strength is loosening with the time. So that's why she was worried about that, and definitely she worried about that, the knuckle flexion and discomfort, coughing and sneezing, and definitely she was representing us with the finger numbness, and she was not comfortable at all. Otherwise, when I asked her asked her about the past medical history, so past medical history was non-significant, or we can say the unremarkable. But on examination, when I examined her neurologically and vitally she was stable. Her BP, pulse, temperature, oxygen saturation, and the respiratory rate are within normal limits. But her neurological examination, upper limb and the lower limb and extremity strength is less, especially on the right side as compared to the left side. Although she was not comfortable with the left side also, but simultaneously she told me that the right side symptoms or right side weakness she felt more than the left side. It means left side also little weakened. Or you can say, if we consider the 4 by 5 power in the right side, so we consider 4 plus by 5 power in the left side, so it means it's an subnormal power. No sensory deficit except the numbness in the right side, which I already mentioned, and otherwise on the left side and other part of the body, sensation were equal and within normal limits. Reflexes are within normal limits. Negative Hoffman signs and normal gait and no cerebellar sign. All cranial nerves intact. I didn't find any focal neurological abnormality in any part of the cranial nerves. Here, definitely, we know that the diagnosis, definitely, I told you before, but definitely we are thinking, definitely what you are thinking, something in the brain. It means your provincial diagnosis is that definitely something in the brain. So what is in the brain? So we are considering here the differential diagnosis. What kind of differential diagnosis, or what are the different differential diagnosis we should talk? For example, if you are in the examination, definitely somebody asking you what kind of the differential diagnosis here, so you can say that the CSF flow and aberration happened here, such as maybe the Chiari malformation or the syringomyelia or the hydrocephalus. So considering that, the other differential diagnosis, degenerative, we consider the cervical spine spondylosis. Same way, the neoplastic lesions. Definitely, the neoplastic lesion could be the cervicomedullary junction, any kind of tumor which are common in that area, and definitely you can understand that there are the chordomas and the meningiomas and the ependymomas, intramedullary or extramedullary tumors, you can name it. Otherwise, maybe the simple thing, vitamin B12 deficiency, or the little neurological problem, we can consider here the multiple sclerosis. So these are the differential diagnoses. As I mentioned earlier, that we are here discussing the Chiari-1 malformation. So how we confirm that there is a Chiari-1 malformation? We did the imagings, such as we did the CT scan brain with and without contrast. We did the MRI brain with and without contrast, with diffusion weighted image, and with, for example, perfusion weighted images. These all are the protocol images which we are doing, and as a protocol for every kind of patient when we are considering these kind of the problems. So here, when we saw that there is a T2 in the MRI brain on T2 weighted image, signals and the sagittal and the axial images which demonstrate the cerebellar tonsillar herniation in the foramen magnum level. So the tonsils have descended more than 5 millimeter through the foramen magnum, and there is a crowding and at the cervicomedullary junction. No hydrosyringomyelia was shown in the MRI or CT scan with or without contrast. So differential diagnosis here, or most probable diagnosis, I could say there is a Chiari-1 malformation. There is no disease coming in my mind which shows the 5 millimeter transgression, or you can say the placement of the tonsillar herniation. I didn't find anything in my mind other than the Chiari-1 malformation. Further workup we did, and as I mentioned at the start of my presentation or that lecture, these are the real patients which I have treated in my life. Definitely, These further workup we did, such as we did the MRI brain, MRI cervical spine to rule out the cervical myelopathy, and the screening for the syrinx, which could be the association with the Chiari 1 malformation or any kind of the problem which we are encountering at this moment. Myelopathy in patient who cannot receive MRI. So that's why what I am trying to tell you that MRI brain we already did, and then definitely MRI cervical spine we did further to check any Chiari malformation or any other thing which may we could miss at that time. Right now, I want to represent here some pathophysiology. Definitely, pathophysiology is from some literature, because I want to convey the information via one case which I represent you, that my patient was 42-year-old. Definitely, as you know, that the Chiari 1 malformation involves cerebellar herniation at least 5 millimeters below the level of the foramen magnum. Chiari 1 malformation may be congenital or acquired. So it could be congenital or it could be acquired. So you are telling in that age, even though the congenital, yes, sometime in congenital, there is some part is transgressed from the foramen magnum, and with the time when the brain become enlarged, in that age some time represent. So there is no ambiguity or no I must say you consider that, oh, at this age, yeah, at this age, at 42 year, yes, at 42 year, patient can represent like that. So if there are the means, for example, acquired definitely because of some reasons, and what kind of the reasons we will discuss with the in this lecture. First of all, as I mentioned, congenitally mesodermal defect during the development can lead to a small posterior fossa. It means by birth the posterior cranial fossa not developed according to the size of the brain. Means the brain in proportion is bigger or larger than the area of the posterior cranial fossa. It means posterior cranial fossa is smaller than the brain mass. So that's why the area is definitely small, and when you are putting the cerebellum and the brain stem in that area, definitely they has been pressurized, and then definitely the cerebellar tonsils or cerebellar mass can come out from the foramen magnum, or it can go up transtentorially, but here it comes down. So it is considered like a congenital Chiari 1 malformation. Here, the crowding at the foramen magnum cause aberrant CSF flow across the craniocervical junction. So CSF flow also hampered, also difficulty for the CSF flow. So in that manner, because of the congenital issue, because the small development of the posterior cranial fossa, this is the thing. Now I want to discuss the other thing now. Causes of acquired Chiari malformation include repetitive lumbar punctures. If patients are suffering from some issues, or whatever the issue, there's a long list for that. I don't want to discuss here because I don't want to drag you from this topic to the other topics. But if any patient has suffering from the multiple or experience the multiple lumbar punctures or lumbar drainage, or chronic CSF leaks, or lumboperitoneal shunts, or traumatic pseudo-meningocele. So these all may cause the acquired Chiari 1 malformation. A cranial spinal pressure gradient across the foramen magnum, in which the spinal compartment has a lower pressure than the intracranial compartment, which can cause a sump effect, and this sump effect pulling the cerebellar tonsils into the foramen magnum, and this is thought to promote the formation of the Chiari malformation. I think it's very clear, and if you listen again the sentence, definitely you would understand what I'm trying to tell here. Now, there is a sequelae of the Chiari 1 malformation is called the syringomyelia. A number of theories have been proposed to explain the development of the syringomyelia in Chiari 1 malformation, such as Gardner's theory, or we can say Gardner's hydrostatic theory, proposes that due to the delayed embryonic opening of the fourth ventricle outlet, there are exaggerated CSF pulsations into the central canal, which then lead to hydromyelia formation. So, this may cause the syringomyelia. This Gardner's theory is suggesting us that because of the delayed embryonic opening of the fourth ventricle outlet, means fourth ventricle outlet not developed properly on proper time or appropriately, so there are the exaggerated CSF pulsation into the central canal, which then lead to the syringomyelia or hydromyelia formation. One more theory I want to discuss with you people here, which is the Williams theory. Williams theory is telling that the craniospinal pressure dissociation. I repeat, Williams theory, which is another theory which is suggesting craniospinal pressure dissociation. Theory notes that there is a difficulty in rapidly equilibrating CSF pressure wave during the Valsalva maneuver, and during this delay the pressure differential between the intracranial and intraspinal space exists, which pull the cerebellar tonsils downward, and then resultant obstruction of the CSF flow between the posterior fossa and the cervical subarachnoid space causes continued fluid flow into the central canal from the fourth ventricle, which is also cause or the theoretical or a hypothesis for that it may develop the syringomyelia. So the pressure gradient difference is causing these issues which I am discussing with you people here. Same manner, one more theory has been conducted, or we can say has been established with the time for what we say to explaining the pathophysiology of the syringomyelia in Chiari 1 malformation is like that, which is the Oldfield theory, and Oldfield presented this theory like that proposes that the CSF pulsation pressure generated during the cardiac cycles derives spinal CSF into the spinal cord, and this leads to diffusion of the CSF through the perivascular space of the spinal cord and formation of the central syrinx or syringomyelia later. So this Oldfield also showing that this is a CSF pulsation pressure with every beat of the heartbeat, which generated and during the cardiac cycle derive the spinal CSF into the cord, and this lead to the diffusion of CSF through the perivascular space of the spinal cord and the formation of the central syrinx. Now that's all for that pathophysiology, but now I will come over the options of the treatment, what options we have and what we prefer according to the condition of the patient. As you know, our patient is a 42-year-old female, and what we can do for her, we could observe. We won't do anything. There's an option. We should discuss with the patient, okay, we want to observe you. Definitely. And recommendation, and when we are telling we are observing you, definitely some recommendation behind that. For example, patient is asymptomatic, patient has no symptom, then you definitely observe. If the radiology also suggestive for the Chiari 1 malformation, and you can see there the herniation of the 5 millimeter or more than 5 millimeter cerebellar tonsil. But patient will understand or accept that because patient has no symptom. But in our case, 42-year-old female presented with some symptoms. So how we treat her, we are now talking about that. Actually, surgery. Patient responded best to surgery within 2 years of symptoms onset, and this early surgery is recommended for the symptomatic patient. As I told you, my patient is symptomatic, so surgery will help her, and we advise her surgery. So what we did posterior fossa decompression, suboccipital craniectomy with or without cervical laminectomy of C1. And C1 usually not very common, it occasionally further level go down. Usually posterior fossa decompression with suboccipital craniotomy with or without cervical laminectomy, it's enough. But sometimes we have to take the lamina of the C1 also. This is the most frequent and people are performing that. Surgery for Chiari malformation, as I mentioned, the goal is to decompress the brainstem and restore the normal CSF flow at the craniocervical junction. In patient with concomitant hydrocephalus or elevated intracranial pressure, the hydrocephalus should be treated first with either VP shunt or third ventriculostomy. If symptoms or associated syrinx persist despite treatment of the hydrocephalus, then a posterior fossa decompression should be considered. So, as I told you, if symptoms are associated with syrinx and persist despite we treated the treatment of hydrocephalus, whatever the treatment of hydrocephalus, I don't want to discuss here, but if you treated the hydrocephalus by EVD or by ventriculostomy or by VP shunting or anything, or maybe the third ventriculostomy by the help of the endoscope, I'm not discussing these things. We will discuss later or in the other videos. But as right now I am on the Chiari malformation, I don't want to distract you people. So the posterior fossa decompression is indicated if the syrinx symptoms are still there. Now, what kind of surgical technique we use? Definitely, I give you the ideas of the surgery, but what kind of surgical technique we use in my patient, in that patient. The patient is placed prone under general anesthesia with the head flexed and secured with the Mayfield head holder. The neck is flexed to open the interspace between the occiput and the posterior arch of the C1. So this was the position what I discussed. And the midline incision, after that we make after all aseptic measure, applying the drapes, then we give a midline incision made from the inion to the C2 spinous process posteriorly. Then staying in the midline avascular plane, minimizing the blood loss and post-operative pain, the foramen magnum and the C1 posterior arch are exposed to the width of the cervical dura. So, as the foramen magnum and C1 posterior arch are exposed for the width of the cervical dura, the bone above the foramen magnum about 3 centimeter high by 3 centimeter wide, means 3 by 3 centimeter in a round position, or you in a box position or in a square position you could make and remove the bone. Removal of too much occipital bone can lead to cerebellar sagging and herniation further. So everything appropriate is good. If you do more than that, then it may cause bigger problems or other problems, and you will go from one dilemma to the another dilemma, which is not good for the patient. In the same manner, the foramen magnum and the C1 posterior arch, as I told you, once you expose appropriately, the C1 laminectomy is performed and the C2 laminectomy is rarely needed. Sometimes needed, but sometimes not needed. So not always, sometimes needed. Generally, the dura is then opened in a Y-shaped fashion or in a cross fashion or in a multiple radiation fashion. It depends upon the training or upon the understanding of the operating surgeon. Y-shaped is very popular. I am usually open with the sometime Y-shape and sometime cross form, and it is both are very good working for me. Many surgeons open only the dura with the thought that restoration of CSF flow may be accomplished with the greater expansion of the basal ergonoid system. The tonsils may be gently separated to inspect for adhesion and covering the outlet of the fourth ventricle. If there are adhesion, you may separate gently so you do not damage the cerebellar elements, or we can say the brain tissue. To help restore CSF flow, some surgeons are using the bipolar cautery to shrink the tonsillar tip to lyse the subarachnoid adhesion. Here, as I mentioned, that I am sometimes using the tonsillar coagulation with the help of the bipolar, because it is shrinking that, because this is the vestigial part, it is not sometimes not workable part. So you can address this thing and you can restore the anatomy, and CSF flow has been improved in that manner. Otherwise, the graft, the dural graft, is then sewn in the enlarged to lower posterior fossa and cervico or craniocervical junction. Artificial dural graft, harvested pericranium or fascia lata may be used for the graft as per the availability and as per the social requirement. And it is a big debate again, I don't want to go in that. In cases involving a syringe, when we are suffering, because my case was not, that's why I am representing in cases you find there's a syringe, because my case this has no syringe, so I did that thing. But if there's syringe, the first line treatment to perform the suboccipital craniectomy is previously described as, and if syringe present, then syringo subarachnoid or syringo crural shunt may be required. But it is still debatable. I did not face this problem in this patient, so that's why I am not discussing here this thing. Some complication we have to avoid. How we avoid these kind of the complication? See, suboccipital craniectomy with or without cervical laminectomy of the C1. So this is the risk of the Chiari decompression includes CSF leak, pseudomeningocele, vascular injury, meningitis. So we have to avoid that. Although occipital cervical instability is a potential complication, and cervical kyphosis or postoperative instability, although rarely seen, but if is that, then definitely you have to address this. CSF leak, as I mentioned, 3/3 is enough. Don't go beyond. If C1 laminectomy you have to do it. So avoid C2. Avoid C2 taking is a totally in a different scenario, and no need here. So when we are discussing this, definitely I will tell you more. In the same manner, sometime for the hydrocephalus, we need to treat with the VP shunting. So the posterior fossa craniectomy that is extended too widely has a risk of cerebellar herniation through the craniectomy defects or cerebellar slump. And this cerebellar slump it's not good for the patient, and patient may suffer some other kind of symptom. This may cause the headache, unlike the Chiari headache is different than, and this cranioplasty to return the cerebellar content, and it is we need to correct this. So I just present this case, and I will try to establish this this library in English also. In the second case with the part 2, because this video unnecessarily getting longer and longer, and I don't want to make you unnecessarily bored with my lecture, but the next lecture for the same topic in the same language may definitely help us. Thank you so much.